thank you all for being here and taking time to learn more about colorectal and anal cancers, topics that are often misunderstood and very often avoided. Colorectal cancer is the second leading cause of cancer death in the United States. There are an estimated 154,270 people in the United States expected to be diagnosed with colorectal cancer, and 52,900 are going to die. Colonoscopies have done great work in cutting the risk of dying from this disease, but it is still estimated that over a quarter of Americans are not up to date on their screenings. Anal cancer is much less common than colon and rectum cancer, however. The number of new anal cancer cases have been rising. The estimated statistics for cancer in 2025 are 11,000 new cases and 2,500 deaths. Today's discussion is designed for everyone, whether you're here for yourself, a loved one, or simply just to be better informed. We'll be hearing from healthcare professionals who bring their medical expertise and clarity, as well as our brave survivors. Together, we will help demystify these cancers, address common questions, and share insights and empower prevention, early detection, and compassionate care. It is an honor to bring these voices together, and we're grateful for their willingness to share their knowledge and stories with us today. This is David Russo. David is going to be our moderator this evening. He is the executive director of Cheeky Charity. It's a nonprofit focused on colorectal and anal cancer awareness, with a focus on LGBTQ+ and underserved communities. Cheeky Charity provides education, resources, support for patients, survivors, and caregivers, while also advocating for increased screening rates and health equity. Dr. Michael Jardula, he specializes in internal medicine at Desert Oasis Healthcare. He believes that really listening to his patients is essential to their care. He says, "I love making a difference in someone's life and knowing that they leave a visit with me feeling a bit better when they came in." He continues, "If a patient trusts me, I feel like that comes from me really getting to know them more than just a set of symptoms and what I record in their chart. He or she is much more to me than just their medical history." He feels that having a sick parent at an early age was an influencing factor in his decision to study medicine. These two gentlemen are so incredibly brave. They are our guests that are cancer survivors fighting the good fight, and it's great to have them here. Right there is Rob Donovan, and he's an anal cancer survivor. And this is my friend Bob Hamilton, who I just met, who jumped in last minute for us. He's a colorectal cancer survivor. He was diagnosed in August of 2022. He has 3 tumors that are remaining in his system. Beforehand, he had regular colonoscopies every 3 years since he was 50. And he had no signs or symptoms until the blockage sent him to the ER. So now I'm going to hand it over to David, who's going to do our moderation.
Thank you so much. And thanks to the Mizell Center for letting us be here. We're here to just have an open and honest conversation. My goal, or our goal, is to just get information that's most meaningful and useful and to you. And I really appreciate all of your coming out and spending your Wednesday evening here to talk about colorectal and anal cancer. I know there's lots of things you could be doing, and we really appreciate it. And we hope that the information that we share is not just for you, but you can go on and share this information with other people and amplify it. So speaking of useful information, I'd love to start by asking you the question, what is colorectal and anal cancer, and how are they different?
Well, colorectal cancer, I mean, as you walked in the door, you got to see a little bit of what a colon inside looks like. But throughout my years of practice, we have certainly come a long way in getting to know what diseases the colon challenges us with. And colorectal cancer can be anywhere from the rectal area all the way to what we call the cecum, which is the part of the large intestines that enters the small intestines. And it's very important for us to make sure that we screen for that. As Scott mentioned, it is the number 2 cause of death in the United States. Anal cancer is sort of confined to the lower part of the rectum and the anal opening. And that's a different set of screening procedures and a different set of risk factors that we see in colorectal cancer. I mean, just as sharing a personal awareness, when I turned 50, which is several years ago, I knew I was practicing this, belief that you need to start screening at 50. Now it's 45. Actually, we've lowered the age. But at 50, if I'm telling my patients to screen for colon cancer, I need to do that as well. And even though I had no family history, no obvious risk factors, I'm called what's average risk patient. I said, okay, I'll do it. Well, I did it, and I actually had an adenomatous polyp, which is a precancerous polyp. So I was shocked and also surprised by anal warts, which I didn't know I had either. So there was a double whammy there for me. It was higher risk for colorectal cancer and higher risk for anal cancer. And that kind of shook me awake and actually kind of changed my perspective on how I take this to my patients. So I'm a big proponent of screening, and I have since had 4 colonoscopies since that time, and I'm currently 67 years old. So in 17 years, I've gone through the colonoscopies 4 times.
I think a lot of things that people are wondering, especially with colorectal cancer, is like, what's causing it? Why has it become the leading cause of cancer death in young adults and the second leading cause of cancer deaths?
Well, I mean, a lot of the theories are now it's diet related. Our American diets are not enough higher in fiber. We're we're eating a lot of processed food, and these can also contribute to colorectal cancer. Also, in ascertaining your family history, sometimes relatives don't want to share that information. Okay, it's considered an embarrassment. Okay, they don't want to talk about that. So that's important to kind of really question relatives, first degree relatives, if they're alive and you're able to talk to them, because first degree relatives with colorectal cancer that really kind of shoots up the risk for you to develop. One of the symptom differences also is rectal bleeding, itching, thinking it's hemorrhoid, okay, feeling a lump at the bottom, at the rectal area. Typically, colorectal cancer doesn't have that kind of symptomatology. It's higher up in the colon, so obviously you can't reach it. And so people don't necessarily think about it until something manifests really serious, whether they become anemic on a blood test or they might have change in a bowel habit. Suddenly they're becoming constipated when they were normally having bowel movements every day. So whereas anal cancer is a little different, it does rear its head, with more notification and more recognizable symptomatology.
I'm curious if we can start bringing you two into the loop, because we're talking a lot about this and we're talking about, diagnosis. What was the journey for you to go from?
I have a long journey. I started 25 years ago when I first was diagnosed with anal warts. And I'm going to say anal a lot here, so everybody just get used to it. Anal warts was something that baffled me, and I want to emphasize that I don't think it's very hard to get. I grew up in the age, I'm 65 years old, I grew up in the age of AIDS and always being safe. To this day, I don't know how I got anal warts, but it wasn't from unprotected intercourse. I'm positive of that. So I don't know if it's that easy to get, but
Well, I mean, I think the virus is pretty ubiquitous in our population. So even if you're not of that risk group, you can still get, women get anal warts too, So I think, like I said, that virus is here.
Right. I now know that I had HPV 18, which is a very reactive strain of the virus. And my doctor at the time recognized that. As soon as they actually had that test, that didn't happen until about 15 years ago, I believe, where they
The
actually
anal pap? Or
they speciated the actual virus that was just not available to me at first. So my body doesn't clear the HPV virus at all. I've had it off and on for 25 years. So it wasn't a big surprise that I actually came down with a tumor because it was so reactive. The treatments, imagine this, everyone, that because my warts did not react very well to a cryo procedure, which is basically just dry ice, they had to burn them off thermally. Now, imagine that. That's kind of an uncomfortable thing. Everybody squirmed for me a little bit because it's pretty uncomfortable. And that happened for 25 years. I had various scrapings. I had topical chemo. Didn't work. It just kept coming back.
Every year you went
Every
in?
year I was checked. Yes.
Okay.
I went in for a anoscopy every year, and I finally got a Pap smear approved after 8 years. They told me it would be easier to approve if I was HIV positive, which I'm not. Because the insurance at the time wasn't paying for men having Pap smears, which is insane. But I finally got it. We speciated it. My doctor at the time knew I was high risk, especially because it was not going away. I had about 4 years of negative HPV tests where it wasn't in the Pap smear, but it was still in my body. And so they asked me to go to 2 years to return in 2 years, excuse me. When you know it, that's when I got my tumor.
Right.
It is just, if I would have done every year, it would have been easier. I was lucky. I was insured. I was highly motivated. They caught it very early. It was 1 centimeter round, which is very small as it goes. And I went through the full treatment here at Eisenhower.
Okay. And how about you for yourself?
Well, I unfortunately am the outlier of the what they say about colonoscopies. I started having I'm 65 today, or this year, and I started having colonoscopies at 50. I'd had some family relatives that had had semi-regular colonoscopies and found polyps, had the polyps removed. Nothing was ever found or an issue. But I had a cousin who died at 25. She was my age. And she had, or not died at 25, but she had colon cancer at 25 and had to have a colostomy. So I was kind of hyper aware of taking care of the inside of my system. I did what I was supposed to do. And 2.5 years after my most recent colonoscopy, I started having severe stomach problems, severe stomach aches. Couldn't use the toilet. Finally, it got to the point after about 10 days that I went to the hospital and they did a CAT scan and said, oh, you have a complete blockage of your colon. And it turns out I actually had a 7-centimeter tumor that was completely blocking my colon, as well as 3 tumors that had either grown from the tumor or had started and then grew into the colon. Not sure which happened, chicken or the egg. But I was given 6 months to live so I went to the hospital on a Thursday. They did the scans, and by Monday, I didn't have a colon anymore. So I didn't have any time to prepare, to talk about, to know what kind of treatments were available. It was boom, you don't have a colon anymore. So I'm the anti-establishment, what you need to do for a colonoscopy, which makes me even more proponent of getting tested. So 2 months after having my hemicolectomy, I saw an oncologist, and the oncologist said, well, let's do some testing to see if you have certain genes and certain biomarkers that might make you eligible for some of these new immunotherapy drugs. So I'm sure everybody in this room that ever watches television has seen the Opdivo commercials. I have been doing Opdivo since October of 22. In fact, yesterday I had my 83rd cycle. I go every 2 weeks for a 240 milliliters of drug injected into my port. All of these new things that I learned about being a cancer patient. But I'm extremely healthy. Well, except for being fat, which is also another one of the major contributors to colorectal cancer is being obese. But I've been this way for 60 years of my 65, so it's not anything that new or happened suddenly. I'm, again, big proponent of biomarkers. If you have any indication that you might be a cancer victim, tell your doctor. And if the doctor doesn't want to do it, go find somebody else, because biomarkers and science saved my life. The 3 tumors that were inside are still inside well, 2 of them, we don't know where they went because they can't find them anymore. The 3rd tumor, which was 5 centimeters, is completely calcified and dead. So at least last test. So, and I didn't do any chemo or any radiation. Chemo is ugly. It's not as ugly as it was 15, 20 years ago, but it's a rough ride. And had I been given the diagnosis that I was going to have to go through chemo and radiation or live with my situation and just pass away in 6 months, I don't know what my decision would have been. But the immunotherapy has been phenomenal. And all I can say is thank God for good insurance, because it's really expensive. Also, because of my journey through colorectal cancer and because of the group that I joined that David is the executive director of, I became aware of anal cancer. I'm like, okay, I've had surgeons in my butt doing tests, and I had a good portion of my colon removed. Why didn't anybody ever screen for anal cancer? And I happen to be a gay man, so that makes me a little more high risk. Actually makes me a lot more high risk. So I went to my GP and said, yeah, could you do a pap smear at my next physical? So he did. Oh, guess what? I have HPV. So because of the HPV diagnosis, I did not have the very highly reactive 16 or 18, but we went ahead and went through scheduling a anoscopy, and fortunately that came back negative. But now they did another HPV screening after the anoscopy, and I'm currently negative. It didn't show any reaction for the HPV test, but now I know I also have to have pap smears every year. Even though I don't use my colon anymore.
It brings up a good question. So like from an HPV screening perspective, does it only show up when a person has a flare-up of HPV? Like will it go back and forth between positive and negative?
It should still be there. It doesn't disappear.
Okay. Gotcha. So, yeah, because, from the genital warts perspective or anal warts,
that's a manifestation. Then those can be removed, and but not necessarily get rid of the HPV in your system.
Okay.
On my end of things, I'm on the front end, so I really want to encourage people to screen. Okay, because we don't want to get to this point.
Right.
Okay, so my job is education in screening. Okay, and so colonoscopy obviously is the gold standard for colorectal cancer, but we have so many other options today that we actually can offer as screening methods that are not as invasive, are very easy for people to do. So like every one of our senior patients and anyone over 45 automatically gets a FIT test sent to them, a FIOBT, a fecal occult blood test. Same thing is Cologuard, which is another test that's good for 3 years, okay? And again, it involves a stool collection, but it's not a very overwhelming procedure to do at home. And like I said, now with the new blood test, that's even better. Okay. The Shield test actually takes blood. It was just approved in 2024 and now is starting to come into private practices. So the options are great right now. Okay. So that's why I say, please discuss this with your primary care physician that, that you are screened every year in some form for colorectal cancer and for anal cancer.
One thing to touch on is for people that are diagnosed, anybody with cancer that that has gone through it and they're NED or no evidence of disease, there's a test called a circulating tumor DNA or ctDNA. Natera has one called Signatera. It's incredibly valuable to figure out if you have any cancer tumor DNA circulating in your body, even before it could be found visually. I don't know if either of you have gotten these ctDNA
I've
tests.
had 3 of them.
I've had none.
Yeah.
It hasn't been offered, and I need to be more proactive on that.
It's another one the insurance companies don't
don't
like.
pay
Right,
They
right.
don't pay for that either.
And like a company like
$5,000 or something.
Yes.
a company like Natera, they have a lot of amazing opportunities to like get support for that. So you can, they'll cover the cost if it's not covered by insurance. And it's worth looking into. Worst case scenario that you do get diagnosed with cancer, just have it in the back of your head to think about clinical trials, to do research, to not just like resort to the first opportunity or the first treatment that somebody tells you to get.
Hopefully you got some awareness tonight. So
Yeah.
Yeah, because that's such an easy test. I mean,
Right.
It is an easy test, and your GP can do it.
Oh,
Yep.
yeah. It's very easy to do. And like I said, years ago when we did it, we didn't have the backup. Okay, it was very difficult to find someone, if we found an abnormal test, what to do with it. Because not many people were even wanting to address it. The surgeons certainly weren't. And now there are several clinics in the area that will address it and will treat it in the early stages, so.
I want to open up to questions, but I want to see if there's anything else, any other
I would
thoughts.
just say that it's so important to get your swabs, your pap smears, anal. I mean, I went through, just to say, even though I was on top of it, it was 5 weeks of radiation, 5 days a week. I got weekends off, 2 rounds of chemo. I lost 26 pounds. It was sickening in every respect. So don't go my route. Even though I was on top of it, it's not fun to treat this. Not at all.
Test, and tell your friends and tell your neighbors and just get tested. And again, you can prevent it if they find it early enough.
Yep. Thank you.
And if they do find it, they can,
Yeah.
dare I use the word, cure it? Well, can you cure cancer? It's pretty close.
Yeah.
And if it's not cured, it's the big NED, no evidence of disease. And that's what we are all working towards, is no evidence of disease.
And we know we can prevent it. So that's both of the cancers we're talking about are two of the most preventable cancers that are out there. I want to open up to questions. I've been polling you, so I'm really curious because I know a lot of new information about any questions that you might have. Any thoughts?
What exactly does the anoscopy do versus anal smear? What's the aim in each one?
Well, anal smear will just identify whether there's the abnormality in the cell types, okay, and the presence of the virus, okay. Anoscopy.
The virus, HPV virus?
Correct. Anoscopy is an actual visualization, so it's a scope that goes in.
I've had 2, that's why I'm asking.
Okay, and so they actually will see and map out the anus, okay, and identify where there might be a cellular abnormality that's physically seen, okay, and treat. Okay.
They also can sample too, right?
Yeah,
In an anoscopy.
but I'm saying anal pap is just the screening for abnormal cells. So it's important when they do the anal pap is they do a complete circle around the walls of the anus and the rectum. Okay, and it's if it's done right, it's a little uncomfortable, okay? Because they're going in there and they're kind of scraping.
Pardon my ignorance about HPV. This first time I heard it. I checked AI. It says it can be transferred through skin contact. And is there a way to prevent it?
Go for
Okay,
it.
well, there's a vaccine, okay? However, initially when the vaccine was released, it was for young children, okay? The thinking being that they had minimal exposure to HPV at that point, okay? And you could make a difference. Now I believe it's up to age
45.
45, yeah, that you can get the vaccine.
Well, and so the vaccine it was called Gardasil 4, and now
Right.
they have a new one, Gardasil 9. And what that means is that it prevents 4 and now 9 different strains of HPV, like 16 and 18, and 7 of the other ones that was mentioned that are not as high risk, but still things to look out for. But there's over 200 strains of HPV. So you can't prevent getting some version of it generally, unless you're living in a bubble.
Right. And also, talk about reimbursement, it's a little tricky with some insurance companies because you have to kind of show the risk, okay? Because it's not a vaccine like a pneumovax or shingles or something that's sort of kind of recommended for everybody. Gardasil is kind of specific and a little costly for the insurance companies, so they're going to be a little bit more restrictive in their approval, okay? So I know when we order Gardasil, we have to go through our referral department, who then checks your benefits, see what's what's available to you, how much it's going to cost, copay, or is it covered? So there's a whole, protocol to kind of getting it. It's not like you can't just go in for a flu shot kind of thing.
And while it's only covered up till 45,
Right.
there are people that get it at an older age.
Yeah, and they'll advocate or they'll pay for it themselves, so.
Now, once you have the diagnosis of having been HPV positive,
I don't
there's
think
no
it-
point
no,
in getting
it's not-
the...
Yeah, it depends what strains you have. Like,
Right.
Because if it prevents 9 different strains, if you have HPV 6, which is high risk, but not 16 or 18, then you might still want to get the vaccine to stop yourself from getting. And it depends like how active you are. And the other thing is, it's not just we talk about cervical cancer, we talk about anal cancer. There's 6 other cancers that are caused by HPV, like oropharyngeal. That there's not really a screening option for that. So,
Right.
like the vaccine is really saving so many lives. And it's really
It'll probably be more widely available as we go forward, but right now there does have some restrictions. So
Any other thoughts?
You talked about the different types of screenings. I'm a colorectal cancer survivor, so I was underdiagnosed and I was sick for 2 years and my tumor was found in the ER. So I know that I have to have colonoscopies
Correct.
forever. So someone brought up the different types of PrEP. I have been told I have to have Go Lightly forever, which is the big jug, and they won't let. She gets to have the Gatorade and the
Miralax.
popsicles and all the things, and I get to come home with the giant jug. And of course, after my diagnosis, I had surgery, and they removed my baseball-sized tumor.
okay,
And they told me, okay, every 3 years. Well, not every 3 years at first, but once I got to that point, they said, oh, you can come back every 3 years, and then you might go to every 5 years. But then I had the Signatera, and I had some DNA testing, and we found family history, and they said, well, you're back to every 3 years.
okay.
So do I ever get to have the Gatorade and the things?
I think that's
Or is it the
probably
jug forever?
that's probably more operator dependent, okay? Because I have, some of our gastroenterologists use like a prescription PrEP, that they get. And I can't tell you how many times I get a colonoscopy report back, inadequate PrEP, come back in a year, okay? Where along my years in being practiced, I've actually had a gastroenterologist friend who used Gatorade and Miralax and Ducalax. Never had a problem with PrEP, with not seeing an adequate exam, okay? So, and it's much easier on you than a Go Lightly kind of thing. But that's not even as bad as the other one that you have to get prescription. It's pretty bad.
Yeah, that's
Yeah.
go lightly. The prescription, it's it doesn't go very lightly. I don't know why
So
they
that's
name
why
it that.
when I write for their screening colonoscopies, I hand them the referral with my prep.